In the first part of this conversation, we explored how modern-day psychotherapy took shape, its key figures, its controversies, and the science that grounded it. In this second part, we move from the field's history to its ongoing evolution. My guest explains how psychotherapy advanced from broad theoretical models to structured treatment protocols, why personalizing those protocols to the individual patient matters, and how we came to understand neuroticism as the thread running through the emotional disorders. We also discussed the development of the Unified Protocol, which is a treatment that was developed to be applied across the emotional disorders. I'm your host, Dr. Dan Cox, a professor of counseling psychology at the University of British Columbia. Welcome to Psychotherapy and Applied Psychology, where I dive deep with leading researchers to uncover practical insights, pull back the curtain, and hopefully have a little bit of fun along the way. If you enjoy the show, do me a huge favor and subscribe on your podcast player, or if you're watching on YouTube, hit the like and subscribe buttons. It's one of the best ways to help us keep these conversations going. This episode begins with my guest talking about the good and the bad of how modern-day DSM impacted psychotherapy. So without further ado, here's my conversation with Dr. David Barlow.
Prior to 1980, as you've learned, you weren't around then, but as you've learned, there was no reasonable system of classifying psychopathology. There was DSM-II, there was the early versions of ICD, but they were really just off the top of a committee's head of what seemed to be right, clinically. And of course, the holy grail of classification in those days, and continuing to this day, was the line between psychotic and non-psychotic. So that was, a crucial line. Beyond that, things were pretty amorphous. The non-psychotic, among the non-psychotic disorders, the prevailing concepts were, of course, psychoanalytic, and one of the most prominent concept was neurosis. And as I've written about in other places, as early as the 40s, people like Eysenck, Eysenck in particular, Hans Eysenck, recognized that, this neurosis is such an amorphous, ideologically based, construct that it's, sort of created out of, not exactly thin air, but it's just really it's a theoretical conception of psychopathology rather than any kind of an empirical derivation. But nevertheless, that was the principal way of classifying people. Then, as you have learned, in 1980 in psychiatry, that was all thrown on its head when DSM-III came out, and Robert Spitzer, Bob would call him, who was, like every psychiatrist in those days, trained psychoanalytically, nevertheless came to believe, and he was a very persuasive guy, that we really needed an atheoretical, empirically derived system of classification that to the greatest extent possible would be supported by data. And out of that came DSM-III. Well, that was the biggest holy war of all. It caused just an incredible split in the field of psychiatry. All these people have been trained in psychoanalytic treatment of neuroses. I mean, that was 80% of what psychiatry was. The other 20% was the more organic treatments and maybe in-hospital, institutional kinds of approaches to psychotic patients. But most of it was, the psychoanalytic treatment of neuroses. So that was interesting to see that unfold. But he stood his ground, and he was a free speech guy. He would appear in front of any forum, and he would debate anybody and he was very persuasive. So anyway, he got that through. And early on, in the early 80s, he invited me to join, not to write DSM-III, which had come out in 1980, but to revise DSM-III. And the first revision was DSM-III-R that came out in 87. So we contributed to that quite a bit, particularly for the anxiety disorders. And then for DSM-IV, where, again, this was all a very political thing in the American Psychiatric Association. So it comes time to do DSM-IV, at least what some people thought it was time to do it. Other people said, no, that's much too quick. He got booted out. He got the hierarchy in APA, little APA, American Psychiatry, say he's got too much power here. He's too much influence. And this was kind of a backlash to his dropping the term neurosis. Say, we need to get some fresh blood in here. So they brought in Alan Francis, who was one of his proteges. But Alan was a very gregarious and popular guy, and based in New York also, in the same department, Columbia Psychiatric Institute. And so, and I had gotten to know Alan pretty well in the DSM-III-R process. So I joined the task force to DSM-IV at that point. So I was running the task force. We made every decision, came through us for any disorder. So that was a interesting experience. This was before the days of computers and email. Everything was, every 2 days I'd get this mailing like this thick, that would say, read these top 15 articles. Very important you read them before we meet again in 2 days or something, I mean, it was just an incredible amount of work. People writing review papers and pulling stuff together and topical reviews and data-based, So anyway, that was all sort of the process. But what he did, of course, was introduce an atheoretical, categorical approach. Now, as I said many times, this was an incredible advance for psychology. And for, at the time, proved out to be, really inappropriate because of the rigidity of it. But at the time, it did wonders for those of us who were interested in a more empirical, data-based approach to psychopathology, because it operationalized the psychopathology itself, for better or worse. Now, these were very thin slices of psychopathology, but it operationalized panic disorder. No, that had never happened. GAD, how did it differ from panic disorder? What was unique about it? And we contributed a lot to that in the mid-'80s. Depression, how did that? Social anxiety. So instead of neurosis, we have 30 or 40 thin slices of what was called neurosis. We go through the somatic symptom disorders, now called something else, somatic disorders, and the dissociative disorders, and the eating disorder. All these things were all just neurosis, and it was due to internal conflicts and etc. So now all of a sudden we have these theoretically neutral, empirically derived slices of psychopathology, which turned out to be much too thin, but nevertheless, there they were. And we could develop protocols that actually evaluated, treatments for these. And it wasn't just drug treatments. Big Pharma loved this development because, they could do their clinical trials on each of these, individual disorders and come up with a new indication that they could get by our FDA in our country, in the States, which you know about. And the world followed. ICD, the process they had for coming up with these things was just a shadow of all of the people they had working on the DSM. And the money was a pittance that the World Health Organization had devoted to this. They had bigger things to worry about. rather than psychiatric classification. So, they pretty much followed us, the ICD, along the way. That is the DSM folks. But so it was good because we could then show that for panic disorder, which was, our area, that was one of our big areas at the time, agoraphobia, panic disorder. We have a psychological treatment that's at least as good, if not better, than our drug treatment. And the same thing for social anxiety or depression. And then Tim Beck, came in with one of the first clinical trials for depression. Very controversial, but it's another story, another anecdote. So I'm good. But it helped us to get our stuff out there. We weren't just junior psychiatrists, that we weren't just projective testers who sat off in a corner, helping the psychiatrists figure out, what was going on with the patient. We actually had major intervention procedures developed based on psychological science that we had developed that were now, based on the early data, effective. Okay, so big advance for us, and for the whole field, I think, but particularly for psychology. So then, to fast forward 10 years or so, by the late 80s, it seemed to me that when you look at the procedures we developed for these different disorders, be it OCD or panic disorder or depression, or even, PTSD was just originated in 1980. So things were just starting with PTSD. But that was controversial. People said, no, we don't need a disorder to describe that. That's not a disorder. But anyway, that's another story. So when you look at these treatments that seem to be successful right the way along, it seemed to me, they all share pretty much the same components. Number one, you evoke an emotion. Number two, you look at their reaction to this emotion in context, whether it be a specific phobia evoked by, let's say, flying on a plane, or, a panic attack that was debilitating and causing a rush to the emergency room, or OCD, where you had an intrusive thought that was unacceptable and therefore had to be suppressed at all costs because it provoked extreme anxiety. In all of these cases, what we do in our CBT approaches is we evoke the emotion using the triggers that are individual to the patient. We lead them through some exposure exercise. We do some cognitive training, we do some Beckian approaches, what's rational, what's irrational, is that as dangerous as it seems? Let's look at the rationality of it, the typical cognitive therapy. Let's test it, what would happen if you actually went in the situation. We used to do in those days also some calming procedures, either breathing retraining or relaxation, left over from the systematic desensitization days with Volpe. And then we would, bring them out and do some basically exposure procedures. Specific phobia, that's simple enough. You do some exposure to the phobic situation or object, variety of ways you can do that, approaching it. OCD, you actually have them think the thought rather than suppress it. And at the same time prevent their ritual that's been suppressing it and therefore prolonging the and you change the way that your attributions and appraisals. So that was the late 80s. And we began developing, by that time we had developed manuals for panic disorder. Beck had developed his manual for depression. We developed our manual for panic disorder and for GAD. And there were some others were beginning to appear. And they were targeted at these narrow slices of psychopathology. But with the notion that, what we're doing is pretty much the same thing. By 1990 or so, I think I wrote a paper on this right around then, as well as a book that was published in 88, where we said maybe the psychopathology really has a lot more in common. At least what we used to call neuroses. Maybe there's something to this. Maybe there are some not the heavy theoretical baggage that Freud imagined, with the wars and conflicts going on, but maybe there are some common processes going on here across the psychopathology, where the individual variations of it that form our slices of psychopathology are not that important, maybe are not central. Maybe there's something, sort of underlying it. And that brought us back to emotions, affect, and the emotion dysregulation that all of these people were experiencing, along with their attempts to escape and avoid, these intense emotions. And the whole construct of neuroticism, which was Ising's construct initially. And he made pains to distinguish it from the construct of neuroses. So neuroticism. At the time, he said, as I've written in some places, back in the 40s, in one of his first papers, he wrote, I don't like the name neuroticism because it's too close to the term neurosis and it's too confusing. It'll confuse people. But it was the best he could do. He had some rationale for, why he came down with that. So when we began thinking about this, and when, in collaboration with some of my good colleagues over the years, Tim Brown, Rick Zembarg, Michelle Krask, Ron Rapay, I could go on about that. I don't want to leave out too many names, but, some of my good research collaborators over the years, we began really looking at this. And it did seem that, all of these manifestations, the thin slices of psychopathology, had some underlying themes. And one of them was emotion dysregulation. The other one was, sort of out of control negative affect, to which they reacted very badly. By avoiding or escaping or otherwise finding it extremely aversive and doing anything they could to avoid or escape it. And the various other processes that contributed to this. So then by 2000 or so this is all the while we're doing our clinical trials, but by 2000 or so, we hit upon the notion that let's come up with one transdiagnostic protocol that might be much easier to disseminate, something that would be much more useful for the clinician. And we came up with, again, during those years, some early conceptualizations of neuroticism being at the core of these these disorders. I was personally inspired to some extent by a British psychiatrist named Chris Fairburn, who was an eating disorder guy. That was what he specialized in. And he had come up in the 90s, and we used to talk quite a bit and see each other at all the different venues around the world. But he had come up with the fact that eating disorder, using the DSM-III concepts, there were like 5 eating disorders: bulimia, anorexia, binge eating disorder, and some variations of that. And he came up and said, this is all the same stuff. This is all really underlying this is a real phobic reaction to being heavy, and various escape and avoidance, and a real cognitive distortion of body size, body shape, body size, almost like a body dysmorphic disorder kinds of, conception, and all the attempts to mitigate those strong emotions that in reaction to weight and body shape, and then all the consequences that occur because of it. The real physical consequences of being anorexic, and in many cases resulting sadly in death. But so he said, we need one treatment, that's all we need for eating disorders. And he came up with this enhanced CBT treatment for eating disorders. So that was a transdiagnostic, but only across eating disorders. And it seemed to me, we can expand that. We can go across all the old neurotic spectrum. And then we published the paper in the early 2000s, on the unified protocol, unified transdiagnostic protocol. And later on, we published, and then with Tim Brown in the late 90s, we began publishing our kind of statistical approaches to isolating the common components of all these, this neurotic spectrum, and coming up with, high negative affect. For some disorders, low positive affect. That was less widespread, but for depression, for social anxiety, interestingly, for agoraphobia, they're also characterized by low positive affect. And the various attempts to escape and avoid, not necessarily the triggering context, whether it be a intrusive thought or a shopping mall for agoraphobia or whatever. We downplayed the importance of that and focused on the experience of the emotion itself, on the emotion dysregulation itself, on the unacceptable, very aversive experience of intense negative emotion, or in some cases, positive emotion. And published some, data showing these kind of core elements. So with those core elements identified, and with the major one being sort of neuroticism, which is, high, consistent negative affect with, continual sort of arousal, we decided that, what needed to be treated was the high negative affect, their reactions to it, their multiple ways, cognitively and behaviorally, they would attempt to avoid or escape it. And that was really the birth of the protocol. So with that, by the 90s, then we began saying, yeah, the DSM-III is really not this was an important way station, made some important contributions, but doesn't reflect nature. As we say in the classification business, it doesn't cut nature at the joints.
And it seems like what the work that you were doing preceded some of the current, like the high top movement, where they're, it's really psychometricians, right? Like to saying, hey, the way that just it's very consistent with the story that I'm hearing you say.
Yeah. Oh yeah, it was way before the statisticians got involved, in as sophisticated a way as they are now. I'm not entirely a fan of that the sort of, let's say, unabashed statistical approach to organizing psychopathology. I think actually they miss a lot along the way. I don't think it's as clinically meaningful. It's not going to be as clinically meaningful as it could be. And that's another story. And I very much admire the efforts they're making.
How would you? What would you think about doing differently, or how to approach it differently?
Anytime you do this, sophisticated factor analyses and things like that, which is basically what they're doing. You're taking a whole bunch of questionnaires, throwing them in a pile, seeing what goes together, and coming up with, the variety of these factors and profiles and things like that. But it's all still very nomothetic, number one. It all boils down to throwing everything in a pot and kind of sort of seeing what comes out now. But then you have to go back to the individual patient. They try to do this. They try to go back and get a little bit categorical by developing profiles. Mm-hmm. There's a profile. Well, there's this profile. There's that profile. These things sort of hang together. But they're so nomothetic that they don't often make a lot of clinical sense to me. And I'm not sure they're going to be really helpful to clinicians going forward. The MMPI had all these profiles. And that was very empirically derived process. So no argument there, clearly a scientific process. But, do you really see much of the MMPI these days? I don't think it really stood the test of time. I think this is, and I'm being a bit harsh here, but I think basically we have a new MMPI, and I don't think it'll stand the test of time.
So you've developed.
I'll catch a lot of hell. That's all right. I'm open enough.
What's that?
I'll catch a lot of hell for that if they see me say this, but my good colleagues in the high top field, one of whom is a student in my lab, a postdoc in my lab at the time. But anyway, that's my opinion.
So you developed this unified protocol, which is designed to sort of focus on manifestations of this underlying neuroticism. A question that I had is, you have these different modules, and the idea that every patient goes through all of these different modules.
Right.
How do you think that the clinician working with the patient should sort of go through them uniformly, or do you think that they should be somewhat adapting them for personalizing them? And if so, how to go about doing that?
Yeah, well, that's an excellent question, right on the cutting edge of research. And although I'm not actively involved in grants and research anymore, many of my former proteges and former postdocs and students are, and that's exactly what they're working on. Because these protocols are and ours is a protocol, even though it's transdiagnostic and coherent. And it's still a protocol, and it's never meant to be applied rigidly. I mean, that's why we all get clinically trained. If it were meant to be applied rigidly, you wouldn't need clinicians. You could just have an AI agent do it or something. But to back up a bit, for example, to support that, one of the problems we would have in our clinical trials was we'd be required to, very wisely, when we're doing clinical trials, make sure we had an independent variable, which would be the treatment procedure. Well, to do that, we'd have to develop these adherence and competence scales that would be applied to every therapist. And there'd be somebody who would be responsible for the adherence and competence ratings. They'd have to look at a sample of the videos of them delivering the treatment. Well, what we found really on was that we would occasionally, and there'd be, 20, 30 therapists involved in some of these large trials. What we discovered early on is that we would occasionally get these people who scored perfectly on adherence and flunked on competence. We say, and we would just see the numbers, and we say, what the hell's going on here? And we maybe bring the rater in and look at everything. And what would happen is that these people were just reading the manuals. They were just reading the manuals with almost no regard for, personalizing it, doing the art of the clinical work, and making sure that they understood it, applied to them, adjusting it to their context, their surroundings, their understandings, their idioms. And the therapists were very incentivized to do this, some of them, because we're getting paid for it. He was and they wanted to keep being therapists. For some of them, that was, was a motivation. I mean, they were good people. They were trying hard, so these protocols were never meant to be, they're always meant to be personalized. Then it brings us to your question. But how should they be personalized? What are the guidelines here? You can't just go out like, the traditionalists did for all these years and say, go out and just form a good relationship. Do the best you can, get the patient to like you and all. And I said, what are the guideposts for making these clinical decisions? Do the patients necessarily need all 5 of our core modules in the unified protocol? Maybe they don't need the motivational portion. So we're now developing, and we have developed actually, we're in the process of developing some assessment procedures whereby we'll look at the various levels of skill. Marshall Linehan, the borderline DBT people do this too. What are the skills, whether it be the cognitive kind of skills, the cognitive understanding, et cetera, the exposure? What are the kind of skills that these people already have that maybe we don't need to really work with them much on that, but we need to focus on ones maybe they're particularly weak. So that's an area that's under heavy a number of grants in that area now. So it needs to be personalized. Yeah.
Because that was exactly the motive, because you have a motivation module. And one of the things that I thought about is, sometimes you have a patient who comes in who's really motivated.
Right.
Right. And then it was like, so then how would you sort of make that determination? So, but it sounds like that work's going on.
Right. So, but in our lab already, clinically, people say, well, we're not going to spend much time on that. Yep, this patient's good on that one. We'll move right on.
Right.
Right. So, we do have a range of sessions for each of the 5 core modules. And that's sort of meant to accommodate the individual adaptations by the clinician. But we're trying to come up with something maybe a little more systematic.
Right. So I just have a couple more that I want to, before I let you go.
Yeah.
Sort of, if I can just random things. When it comes to patients that don't improve, what do you think in terms of some of the the potential ways forward for looking at treatment resistance or whatever you want to call it? What do you see as the most, possible or exciting potential ways forward for helping these folks?
Yeah. Well, that's an excellent question and a subject of, intensive research. It's always been a big topic in psychiatry. Psychiatrists go around giving workshops on treatment-resistant patients. But the usually solution is, okay, they can do well on this drug or drug number 2. Here's drug number 3, maybe drug number 4, maybe combine them. So that's the typical outcome of that kind of workshop. In our case, obviously depends on a careful analysis. To me, in my mind, a careful analysis of behavioral analysis of what's going on, and there's a lot of different reasons. And I think with a careful behavioral analysis, you can often come up with some adjustments that need to be made. I think, and I'll give you an example in a minute, but unfortunately, this all hasn't been systematized very well yet. And I think this is something that very much needs to be done. So, I had a patient once who was a PhD in education, a really bright guy. And he had panic disorder. And we went through the whole rigmarole. And panic disorders, one of the disorders with which we have the highest rate of success. Mm-hmm. It's fairly, as long as there's not a whole bunch of comorbidity with it, we can usually deal with that very well. This guy, in session, he would understand everything. He could spit it back. He could teach us. He could teach the next patient, the concepts. But he wasn't getting better. I mean, he used to. The funny thing was, he used to love the flats, the tracks, the horse racing, and he would go, and he was an excessive gambler, but he would go. Nothing was more exciting to him than watching his horse come in, win by a nose or something. We go say, call him Jack. We say, Jack, what are you feeling at that time? Oh my, I feel just total excitement, and yeah, heart rate is up. I might be perspiring. I might, short of breath. I'm so excited and all that. Hey, Jack, isn't that just exactly what you told me you feel when you have a panic attack? Why is this a good feeling? And it's not, when you have your panic attack and it makes you totally shut down. And he would understand that rationally. It's the old notion of, you get the battle between the rational and the emotional. But when he was having one of these episodes in the context in which usually school, the negative thinking, everything would come out. In his case, really, I found just trial and error that it really was just perseverance. I just kept, and I found this with a number of patients. I just kept hammering this home, example after example. And even though rationally he knew it, he just needed more intensive treatment. This is one example. In another case I had, was a woman who was severely housebound. And her story briefly was that she had been married to a guy in New York City who turned out to be, and they lived very comfortably, they had lots of money. But she never really knew what he did, how he made this money. She never quite understood it, and he always put her off, when she would inquire about it. Well, it turns out, to make a long story short, he was a mobster. He was a mobster, and in the space of a couple of months, they got him on trial, went away for jail for decades. She was left with nothing, and she had no family to fall back on. So she went from this, great lifestyle to being almost homeless. When, as luck would have it, she happened to meet a guy who became her white knight in shining armor. And they hit it off, and he married her. He took, some things in between. But shortly after that, he married her, basically rescued her, and he moved off to another city, his city, where he lived in New England. And so years go by, several years go by, and she gets referred to us. She's housebound. She's absolutely, anxious and can't go out and housebound. And basically, again, make a very long story short, we treated her, nothing worked. Wouldn't budge her. She was a very reasonable person. And once again, rationally, she understood everything. Nothing worked. And then it turned out her husband was a pretty controlling guy, right? So he was very nice. He never rose his elevated, he never shouted, never rose his voice, nothing like that. But there were some rigid things she had to do. His mother had to come to dinner twice a week. Yes, that was what they always did, and she had to cook the dinner. He had other rituals, other things he had to do. The house had to be a certain way. Da-da-da-da. And all of these things would keep her kind of occupied. Anyway, so that's the context, which I'm leading into. So then, again, the fates took hold. And this guy develops aggressive cancer and up and dies in like 2 months. He was a young guy, in his maybe early 50s. And of course, in all the commotion and the crisis, I wasn't seeing her at this point. This was my patient. And next thing I know, maybe 5 or 6 months later, I run into the person who had referred her in the first place. And I say, "Oh, whatever happened to Jane?" So Jane, what happened to Jane? I mean, is she okay? It's terrible about her husband dying. And this friend said, "It's the most amazing thing. She inherited a lot of money. She did as well. And she seemed to get better. And she was out and about, and she picked up and moved back to New York and rented a flat, and she seems to be fine." She says, "I don't know what happened." So there was nothing I did. What happened was turned out to be some dynamics, some marital dynamics going on there, where she had lost all control over her life, but owed this guy, this knight in shining armor, was so overwhelmingly in debt to him for rescuing her that she could not object. She could not bring herself to say, "No, I really don't want to see your mother twice every week. I didn't like you. I don't like your mother." Or, "No, I'd really rather go out and do some of my own things." He wouldn't let her, He was extraordinarily controlling. But she was unable to, bring herself to deal with it. So in that case, the agoraphobia was sort of, you call it pseudo-agoraphobia or whatever it was, but it seemed to be a function. So you could say, well, that's a psychodynamic sort of thing. Well, you could say you could do a good behavioral analysis, and see that, so sometimes you get these things. There are a number of cases like this, where you get these sort of anomalies, you get these treatment-resistant cases. In my experience, a lot of them are different. And, there's still ways to go to sort of untangle maybe how we could teach clinicians to systematically evaluate these things better. But it's another example of, you can't just do a manual. You have to be ready for. We know that 30% of the people, 70% are going to do well. Half of those people will be pretty much cured. The others will do very well. They're really functioning much better. 30% will either not be doing that well, it might have improved a little bit, or not doing well at all, or in some cases they've gotten worse. Occasionally we see that. Then you have to sit down. Never give up. I tell my students, never give up. Persevere. Get in there. You're missing something. Get in there and do the analysis. Try a different direction. And keep working with the patient. Don't just say, well, too bad, good luck with the next therapist or something.
Well, on that optimistic point, but before I let you go, you've written so much. You're so prolific. But for listeners, if we wanted to point them to a handful of resources to sort of like learn more about your work, what would be like the handful, the couple that you might suggest? And I can put those in the show notes. That way people can go jump to them.
Sure. Could I just send you 2 or 3 articles?
Of course.
I would choose. Yeah, I'll just do that.
That'd be absolutely wonderful.
Yeah, I'll send you a couple of reprints would be free to distribute.
Okay. That'd be great. Dr. Barlow, this has been, I'm sorry, go ahead.
Yeah, one for the Unified Protocol, maybe one for neuroticism. Yeah.
Yes, that'd be great. That'd be great. Well, I can't tell you how much of a thrill this has been. I just so appreciate you being generous with your time. It's been wonderful.
I'm talking with you, Dan. Yeah. I never had a problem with talking with my students.
Thanks so much for watching. If you found it helpful, please like the video and subscribe to the channel. I'll see you in the next video where we continue exploring the science of psychotherapy and applied psychology.